Is there any way that we as a community can make the process of diagnosing ALS more standardized across the board? Is there things in which one institution may do it one way and another institution may do it another way, and that we can kind of align a little bit more in the middle on how to kind of do things, I guess, per se?
Yeah, so Marco, this is going to be a little bit of a longer answer to you, maybe in two parts. One, I think the concept of having an objective biomarker that can indicate that you have ALS, or that it may support ALS, if not confirm ALS, would be great to have. And the ALS Association, where I am Senior Vice President of Research, we have funded a lot of research in looking at both diagnostic biomarkers, progression biomarkers. One of the best candidates we have right now is neurofilament light, or NFL. And the idea is that NFL is elevated, and we've seen this across many studies in ALS. And there are several companies now out trying to develop commercial. There's already commercial assays available, but clinical grade commercial companies that are trying to develop these assays so that it can help a neurologist or a clinician use it as a supportive tool. Having said that, I think another maybe another way to answer your question is sort of how do we kind of bridge that gap between what the specialists know and what the non-specialists know, right? It is to make sure that we can educate clinicians to steer away from this conventional wait and watch approach until all the textbook diagnostic criteria for ALS are met. Instead, initiate prompt referral of suspected ALS patients to the nearest multidisciplinary ALS centers. That's sort of how we bridge that gap. And yes, there is a worry that, there might be too many false positives, right? Because if you're taking suspected cases and just sending them to ALS specialty clinics, but we think that small trade-off for reducing high rates of sort of delayed or erroneous referrals of true ALS cases is okay to have. It's just a small trade-off. We do need to increase confidence of non-specialists for early recognition of more common ALS features. And this takes me back, Marco, to the publication that we're talking about today. Within this publication, we have published a really simple diagnostic tool called Think ALS. And this is really easy to use symptoms guide that provides commonly presenting clinical features, but also features that may be further supportive of the ALS diagnosis, or maybe features that suggest this may not be ALS. And what this tool does is provides that if you are thinking ALS, make sure you write down in your referral ALS or clinical suspicion for ALS, and write down urgent. And the reason for that is so that, a lot of the ALS referrals, they contain these broad symptom terms like weakness and gait abnormalities, and which ends up getting these referrals routed to like a general neurology triage pools. And the wait times for that neurology triage could take several months. But if you write down urgent, and we also provide a QR code which allows the referral to be sent to the nearest ALS specialty clinic, what you can do is, ALS centers can triage and schedule these first consults within maybe 2 to 4 weeks. And so they can reduce, time to diagnosis. So I think that is the way we think we can start to standardize some of this ALS diagnosis. I think you asked a really important question about geography, or, do we see variations across the board? This is something the ALS Association is now starting to look into as a follow-up to this study and try to understand, what parts of the United States have the highest diagnostic delays. And again, they may be related to education of clinicians, they may be related to our, just general healthcare delivery. But this Think ALS tool tries to provide a more objective clinical framework as opposed to a more subjective way of diagnosing ALS.